So thank you for the opportunity to share these results, which I'm doing on behalf of the Children's Oncology Group and my co-authors. Cure rates for children, adolescents, and young adults with ALL have improved dramatically over the years, but relapse still occurs in 15% of patients. And survival is poor after relapse for patients who do relapse, especially when the relapse occurs early after diagnosis, or when the patient's relapse has measurable residual disease, or MRD, after the first month of therapy. Standard treatment approaches for these high-risk relapses includes intensive chemotherapy for 3 to 4 months, followed by a hematopoietic stem cell transplant. Blinatumomab is an immunotherapy drug that binds both a patient's leukemia cells and their normal immune T cells, causing the patient's normal T cells to kill the leukemia cells. Blinatumomab is FDA approved for patients who relapse or those who don't completely respond to chemotherapy. The objective of our trial was to determine if substituting chemotherapy with blinatumomab as consolidation after initial induction chemotherapy could improve survival in young patients with first relapse of B-lineage ALL. Our trial included patients from age 1 to age 30. These patients received 1 month of induction chemotherapy, and then the patients with early relapse or late relapse that had high levels of MRD were randomized to receive either chemotherapy, arm A, or blinatumomab, arm B, followed by transplant. We plan to enroll and randomize 222 patients on this trial. After 208 patients were randomized, the trial was closed early when the independent data monitoring committee determined that the arm B blinatumomab was superior. The primary endpoint of the trial was DFS, which is survival without relapse or disease progression from the time of randomization. And this showed that the blinatumomab was associated with about a 20% increase in DFS compared to chemotherapy, with an average follow-up of about 1.5 years. A secondary endpoint was overall survival, which was also approximately 20% greater in the patients treated with blinatumomab compared to chemotherapy. The improved survival with blinatumomab was likely related to 3 major factors. The first was the patients treated with blinatumomab were much more likely to have the residual disease in their bone marrow cleared than the patients treated with chemotherapy. The second is that the rates of serious adverse events were much lower in the patients receiving blinatumomab compared to chemotherapy. And the primary adverse events that were seen with chemotherapy included life-threatening or even fatal infections, and this was not seen with blinatumomab. And then finally, patients treated with blinatumomab were far more likely to successfully proceed through therapy to receive a bone marrow transplant. Given the fact that transplant is the treatment most likely to cure patients with relapsed ALL, this third factor is particularly important. So in conclusion, for children, adolescents, and young adults that have a first relapse of B-lineage ALL that is either early or MRD positive after the first month, blinatumomab is superior to chemotherapy as a post-reinduction consolidation prior to transplant. And this is due to fewer and less severe toxicities, higher rates of MRD response, greater likelihood of proceeding to transplant, and improved disease-free and overall survival. Thus, blinatumomab constitutes a new standard of care in this setting. We will be attempting to build on these results by optimizing immunotherapy in relapsed ALL with strategies such as combining blinatumomab with checkpoint inhibitors, attempting to use immunotherapy to replace or augment reinduction chemotherapy, and studying the ability of CAR T cells to replace or augment transplant. Thank you for your attention.